Hi, and welcome to this edition of Peak Life. Today we're talking about the opioid crisis in our nation and right here in our own city. Joining me today is Joseph Slovis, Director of Chesapeake Integrated Behavioral Healthcare, and David Dillon, Prevention Specialist. Thank you for joining me.
Thanks. Thank you.
Now, we are in a pandemic and the opioid crisis just continues. Can you tell me what effect has it had on the eastern region of Virginia?
You know, it's interesting, Karen. Right before I came, I looked up the stats just to see, how we fared. Eastern Virginia is at about 5 overdoses per 100,000 population in the area, and that's everything from Williamsburg to Eastern Shore. And we saw a 6% increase in the first quarter of 2020. Chesapeake specific has had 40 overdoses in 2018, which is about 16.5 per 100,000. So Chesapeake has been higher than most over time.
Wow. Now, what are some of the possible contributing factors that may play a role in opening someone up to becoming addicted to opioids?
Well, one of the things I think, and Dave can chime in as well, but one of the things that to know if a person has a problem with opiates is, first of all, you look at, has this person had an increase in usage over time? And most folks can see that in family members. The other thing is sort of an obsession with getting the drug. Usually it starts out with something saying, is it time for me to get my medication yet? If it's a pain medication, that sort of thing, you'll see the increase. Then as addiction progresses, what you'll see is more obsession with the drug, getting the drug, making sure they have it, spending more time obsessing over the medication. Then finally it gets to the place where it starts interfering with family and work, what you also see is an increase in usage and also getting sick when they don't have it, the withdrawal.
So It could start out like as from an injury or surgery where someone is actually prescribed.
Right, and I was going to, we show several videos that show individuals who had a surgery and were prescribed a painkiller because, of course, the pain was pretty serious, but developed a habit for it. One thing we tell our citizens is advocate for yourself when you go to your physician. You don't have to take a 30-day supply of Oxycontin or Vicodin. Start with the 7-day, and then if you still need more, do it like at a seven day at a time basis, because you can get addicted to an opioid within a 2-week period. It happens very quickly.
And that is very scary, because I would have never have realized that, because most of the time I think if you have surgery, and I recently had a foot surgery a couple months ago, you're not going to get more than maybe a month's supply, which you may not necessarily need to take that. That's actually more than enough, like you said, to become addicted.
And then we have that issue of people saving their medications, and we'll get into that later. Then they're saving them, or they're putting them in their medicine cabinet, and that could lead to more trouble.
Yeah, Karen, it's funny as you said about a month's supply of medication. Typically, you don't even see that now. Over the last probably 2 years, you see a real decrease. People are talking about numbers of pills, not lengths of time.
Right.
Yeah. So that's a positive thing. Yeah.
Definitely. And I think though, like if someone does say have pills that they don't use all of them, say maybe the first couple of days you use it, and you think, well, let me hang on to that because maybe I might need to use it down the road.
Yeah.
Is that a wise decision?
I think as long as you don't keep it too long, and you have to be mindful where it is, and you have to keep up with the count, because people will go in your medicine cabinet, whether it be someone who cleans your house, someone who provides some home health care, and they look.
Our family member could go in,
family member,
and someone who may be looking for that
they just
medication.
Be curious about, they've heard about opioids. It might just be curious about the effects of it.
So, how has the pandemic, we were talking about the pandemic, what are some of the ways, like has it, someone maybe losing their job because of the pandemic, or maybe just not having that social connection that we've been able to have, has that affected the problem, do you think?
Certainly, I think we've seen an increase in the number of people that have come in for addiction services. But it's interesting, when the pandemic started, we actually saw a decrease. And the decrease wasn't that the people weren't having a problem, the decrease that people weren't coming in. Also, the same thing happened at Chesapeake Regional Medical Center. I can't remember if it was March or April or May, but they had a month where they saw no overdoses. And that's a rarity for them to do that. And part of it was people were suffering it out at home, or they weren't bringing family members in who had an overdose and that sort of thing. Now that number's since recovered some, but you know, the pandemic was a sort of a way of hiding things. You know, people were, even addicted folks were concerned about getting COVID.
Yeah, and let me add this, Karen. We work with teens and families, and not being able to go to school, not having that support system at school. For a lot of kids, their support system is their school. So if they're dealing with issues at home and they're not being able to get away from that environment, that may lead to an initiation of use or a worsening of substance use if they've already started it.
And it makes someone more vulnerable to become addicted.
Right.
So I know we talked about this like a couple years ago when you both came on here, and we talked about like someone who, you know, makes a choice. They make a choice the first time. But after that, can we talk a little bit about how, like, literally your brain changes? Is that correct?
That's correct. Yeah, that's correct. You know, we have to realize that, you know, addiction is not a disorder of will. It's a disease process. And there's biochemical changes that occur in a person's brain that increases the likelihood of continued use. And, you know, we could spend a lot of time talking about neurochemistry, but basically it's changes in how the uptake of neurotransmitters occur and what is attracted to certain neurotransmitters that continues the addiction process.
So, and for family members, I'm sure that's tough to
Oh, sure.
think, you know.
Yeah, because everybody says, well, if you really didn't want it, you could just stop.
Yeah.
Well,
Right.
it's not so.
No, it's not that
Yeah.
simple.
It's not that simple.
Yeah,
'Cause
it's
that-
not simply a willpower thing in any form of addiction. So,
That's exactly right. Yeah, if it was a willpower thing, people would quit.
yeah.
Absolutely.
isn't.
It's not.
Right.
So talk about these. You brought some of these with you today.
Right. So one of our campaigns that we have in prevention is called supply reduction. And anytime we have an outing or we supply some of our community partners, we give them these drug deactivation bags, which on the back, it's pretty simple instructions. You open the bag, you put in the desired medication. It describes how many pills, how many patches, or even liquid can be added. You fill it halfway up with warm water, shake it up, wait about 45 seconds. Now you can reseal it, and now it's safe to dispose in your garbage.
Okay.
Yeah.
So as opposed to just taking your unused prescription and just flushing it down
Flush it down the commode,
or
throwing a prescription bottle with medications in your trash, because people will go through your trash and look for meds.
absolutely.
Yeah, so this is just one strategy. So we partner with police and fire. They have a display over at on Albemarle. We're partnering with Chesapeake General, the hospital and clinics. We partner with libraries. So if you go into a library, you'll see a rack with these disposal bags in them.
Okay. And so someone can just go into the library and get one of these if they need it.
Yeah.
Okay,
Absolutely.
that's great. And again, you mentioned that over at the police department, there is a little take-back box as well. So there is a way for people to dispose properly
yeah.
of these, which will eliminate, hopefully, someone being able to get a hold of those pills.
This past Saturday, we had the National DEA Drug Take Back Day. We promote that. And our box over at the Maine Police and Fire has done very well as far as collection medication. So we have to expand that program. We put to another precinct.
Great. So what strategies is CIBH doing to address the treatment needs for opioids, people who are addicted to opioids?
Well, you know, we've always treated folks with opiate addiction. And one of the things that we just started on July 13th was office-based opiate treatment, which is a comprehensive program that many of the other community services boards in the area have adopted. And we had referred folks out for what's known as medication-assisted treatment. Many people understand what methadone is. Methadone is a heroin substitute. We don't use methadone. We refer folks out for that. But we started a program that provides wraparound services for individuals with opiate addiction. We provide case management, individual and group psychotherapy, and the medication-assisted component, which we had referred out for before. That means that we're now prescribing buprenorphine as one of the drugs that we use, and Vivitrol. Buprenorphine is a medication that, along with naloxone that David will talk a little bit about in terms of rescue drugs, does two things. It is a opiate agonist, which means it takes up some of the receptors in the brain and blocks the ability for the individual to get the physical sensation that you'd get from other opiates. And then the naloxone is a drug that takes away the withdrawal and the cravings. So with those medications, we've been pretty successful in helping folks for years. And we just started that on July 17th, and we have now started enrolling folks. We started initially with some of our community partners. Chesapeake Regional has been very innovative in what they developing a program from their ER through Dr. Ben Feckenshire and at the time Kurt Hooks, who was the director of behavioral health at the time, where if an individual comes into the ER with an addiction to opiates or has had an overdose, they're willing to start them on that medication in the ER because you want to hit people when they're most motivated.
Right.
And they would start them on buprenorphine and then refer out to a partner agency like CIBH to provide continuing care after 72 hours. That's been really important. Their program is called the PROUD Program for Prevention, Rehabilitation for Opiate Use Disorders. So we've been real happy to work with them and to start that program at CIBH.
So Revive, talk about that, the Revive training and...
Yeah, it's a state program called Revive. It's a layperson's training that involves teaching people how to identify someone who may be using opioids versus someone who may have overdosed. Okay, excellent PowerPoint. We since the pandemic we are doing virtual, so they're still available. Like Joe mentioned, naloxone is a medication that helps reverse an overdose of an opioid. Okay, and for some reason it's not an opioid that's causing the issue; it causes no harm. Okay, and it has a greater affinity or attraction to the receptor sites, so it literally knocks the opioid off the receptor sites in the brain long enough for the person to revive and get conscious again.
So first responders carry this as well?
Yes.
Or do they? Okay.
Yes. And while supplies last, anytime we do a training, we offer a free twin pack of the
so
Narcan.
Someone maybe knows someone who has an addiction problem.
Right.
They can learn how to administer it. Okay.
Absolutely.
So who are your community partners? I know you mentioned Chesapeake Regional.
Yeah, we're also closely working with the fire and police department on that. We'll partner with just about anybody. This is an important thing for the city. Reason I mentioned the hospital is oftentimes, police and fire are bringing folks to the hospital, and the first thing we want to do is we want to save the person's life.
Absolutely.
We'll work on the addiction, but if they're not living, you can't do anything for them. So that's why it's important for us to address those issues with them as soon as we can.
So I think a lot of people, anybody could become addicted, correct?
Yes, ma'am.
I mean, a lot of people may have an image, well, someone who's addicted to drugs is someone who maybe, would go down that road anyway, but that's not true. It could be you or I or anyone.
Actually,
who's susceptible.
It's something David usually says, the majority of people that are addicted today are not people who started with street drugs. They're folks that started with prescription drugs. Right. And I don't know what the statistic is.
They say, and this is nationwide, 75% of people who get addicted to opioids start with prescription drugs. Most of those get it from a friend or a family member. Yeah. And it cuts across socioeconomic status. There's no, picture of an addict. You look in the mirror as who the picture of the addict is.
Absolutely.
It's anybody.
Yeah. And then you said, once you may not be able to get a hold of or narcotic, maybe you'll go toward heroin, which is a whole nother level.
Another ball game.
In the last 2 years, we've seen a lot more education of practitioners. If memory serves me correctly, I believe all physicians now have to take CEUs that are related to opiate prescriptions. And the most important thing about that is they not only tell them what not to do, they tell them what to do. And that's really important because early on in the opiate crisis, a couple of years ago even, folks were cutting folks off.
Right.
And that's the worst thing you can do, because what that does is that says, now you have to get your drugs someplace
Right.
else. And oftentimes that's illegal sources, and there's no monitoring of quality, or there's no monitoring of tapering on that. So now it's telling folks that you can, how to taper folks off, knowing that limiting the number of pills you give in prescriptions, and in some cases even educating folks on, if you do become addicted, this is what you do.
Yeah,
So-
and the state implemented, and this was a couple of years ago too, I think, Joe, a physician prescription monitoring system,
Yeah.
where if a physician prescribes a prescription to a person, then they track that. So if they go to another one,
Right.
they'll be able to see it. You just got this 7 days ago, so you know what happened.
Right.
Yeah.
So, what can people do to seek treatment?
Well, obviously they can come to CIBH. We're the city's premier and primary public behavioral health program. What we do is, as I mentioned before, is we take a comprehensive approach to treatment. We will contact a person's primary care physician if there's a problem. If a person's in acute need, we do intakes every day, Monday through Friday. Our emergency services works 24 hours a day, 7 days a week. If there's an acute problem, if obviously somebody's in overdose, they need to go to the ER, call 911. But we'll provide follow-up services to them as soon as they can come in. So we're excited about that possibility. It's something that we've wanted to improve on, and now with our office-based opiate treatment, we decided to do things in-house because we have a little more control over the quality of the
Right.
services and the speed at which we can do it. And we definitely take a team approach to doing that. Anybody that comes in for services, we have a treatment team that works with them. It isn't just a one person, one time. So we're concerned about the long haul, because that's what you have to do with addiction.
One thing we emphasize in any of our trainings or community events is the stigma of seeking treatment. So that's one thing we always talk about CIBH services and the intake process. But if we can get people to kind of realize that it can happen to anybody,
Absolutely.
there's nothing wrong in seeking treatment. I think treatment is much more available now for opioid use. And just to get them moving that mindset, as far as getting over like the shame of having an addiction,
Absolutely.
that to me is the biggest barrier.
Because
Because
you
we have
can
the-
recover.
We have the
Certainly.
resources now.
Certainly.
We have the resources.
The most important thing to recognize today in COVID-19 is we're providing a lot of virtual services. If an individual calls up, we can do video conferencing capabilities. We have video conferencing capabilities in our building. If somebody comes in and we want to still maintain social distance with a provider who's off-site, we can do that. We can do our intakes over the phone. In a lot of ways, the COVID-19 has helped us think out of the box in terms of how we provide services. So we've done that. When we do, if you name a platform, we've tried it in terms of video conferencing capabilities. So we can definitely connect with you.
Okay, great. Well, thank you both for being here to talk about this very important topic. I really appreciate it.
Thank you.
Okay, thank you, Karen.
Well, that does it for this edition of Peak Life. And remember, if you or someone you know has a problem with addiction, there is help and hope. See you next time.